I'll just run everyone through the agenda for today and then give a bit of a quick introduction and then let our speakers take over. So first, we'll be doing a quick introduction. I'll just be introducing the topics and the speakers that we have for today, as well as some information about the Webex platform and how you as attendees are able to use it. And then we'll be diving straight into our first presentation on rapid reviews and specifically rapid reviews on clinical management from Dr. Luke Bush, who works in Cape Town. And then we'll be having a presentation from Dr. John Messina, who works in Zambia on COVID-19 response in Lusaka. So first, just to go over that first housekeeping piece. Oh, and then lastly, we will be having a question and answer section at the end. And this time we're going to change it up a bit and allow for our attendees to ask the questions. So you can use the Q&A section on the right-hand side of your panel to submit questions while presentations are going on. But also note that you will have the opportunity at the end, after both presentations, to actually ask your questions to the speakers as opposed to my asking them to the speakers. So we're excited to bring in that sort of discussion at the end. So I'm now going to go into just the general functionalities of Webex and how to use it. So just as a note, all of our attendees are automatically muted when they join the webinar. This is just to ensure that we don't have any audio interruption during the presentations and to also allow for stronger bandwidth for our presentations. Once you have questions, or if you do want to chat during the presentations, you can use the chat functionality, and that allows you to submit chat or questions to either all of the different participants or to myself if you have a question. If you have any technical issues throughout the presentation, you can feel free to message myself and we'll work to support you. And then, as I spoke before about this, there's the Q&A panel on the right-hand side as well. This is where you can submit your questions and they can be, answers can be provided via the panelists. Another thing to note is that in the chat, we will also be submitting 2 questions to you all to think about for our first presentation. And then that can sort of build into a discussion for later on during the Q&A section. So now moving on to our presentations, we have, as I spoke before, our first one is on rapid reviews and basically the process of creating rapid reviews and a little bit of detail into some of the clinical management rapid reviews that are being produced right now by the Emergency Medicine Division of the University of Cape Town. And this is specific to the Western Cape context, but can be expanded to apply to a variety of different contexts. And we have Dr. Luke Bush, who is co-creating these rapid reviews, to walk us through the process of these reviews and then also dig into a bit of the details as well. And then following that presentation, we have Dr. John Messina, who works in Lusaka at Levi Mwanawasa University Teaching Hospital. And he's a part of the COVID-19 response team there and will be giving us an update on the different challenges and successes that Zambia has had in managing the COVID-19 pandemic. So I am going to stop speaking now and allow for our incredible speakers to take over. So Luke, I'm going to allow you to begin presenting and feel free to start whenever you're ready.
Thank you very much. Thank you for the opportunity. Most of my time is spent in an emergency center, but for the last 3 months, I've had the opportunity to get involved in a few other projects. And one of them is the development of some rapid reviews for the emergency center. And what I'd like to take you through is just some information with regards to the rapid reviews themselves, and then also looking at some of the clinical information that is in the rapid reviews. So we're first going to look at a little bit of the context that we find ourselves in, our context in the Western Cape, and then the rapid reviews themselves in terms of the process of putting them together, what the intent was, and what can possibly come out of it. And I'd like to sort of encourage anyone who's listening in or listening in at a later stage that this process is not only applicable to COVID-19 and that the way of presenting information is relevant in all our settings. And so I'd encourage you to either use these or this format or another format that is similar, that brings across information to people in your specific contexts. So let's get into it. So this is us, and we have a new disease. And this new disease has challenged medical science, it's challenged society, and it's our body's response to it, both from the initial infection and subsequent phases of that infection and the inflammatory response thereafter and complications involved, has provided both medical science and society with a significant challenge. And as a result, there's a lot of fear. Now, the virus has spread around the world incredibly fast. That fear not only relates to the disease itself, but the consequences of our response to it. And that includes the shutting down of society, the closing of businesses, the potential loss of income, and the knock-on effects. Within that fear, it's bred widespread information, misinformation. And I think we've all seen this, both in the medical field, but also within social media. And as a result of that misinformation, it's just often bred more fear. And we all live in most of us live in dysfunctional systems somewhere. And this pandemic has brought out a lot of the dysfunction within those systems. It's not just speaking about our healthcare systems, it's speaking about the politics involved, the decision making, and it all comes down to the leadership structure above us. It's political leadership, it can be a hospital leadership, leadership within your families and leadership within your communities. And some countries have had fairly good leadership, and other countries have had leadership that has taken questionable paths. And it's very difficult because it is all grey. There is no black and white. A decision made today could be wrong tomorrow, and the ability to adapt and change is very important. And a lot of that comes down to communication and communication failures. It's very difficult to communicate when we don't have evidence, when we don't know the outcomes. And so leadership that has been willing to change and adapt as the pandemic unfolds is better likely to respond. Now, part of the communication from an EC and bringing it back to what we can achieve in an EC was developing content for our emergency clinicians in South Africa, but mostly in the Western Cape. That's my context, and that's where I work. And so I can only really speak to that. And part of that information is to synthesize what's out there and simplify the complex into something that is context specific, but that also has a wider applicability, that is engaging. And no one wants to read any content or engage with any content that they find boring or that they can't access on a mobile device in a short period of time. And that it also needs to be relevant. There's no point in speaking to emergency clinicians about ICU care or therapeutics that isn't going to be involved with their daily management. And so picking out and selecting content that is relevant to the people that you intend your message to be. So I call that communication, but what it really is actually a message, because for communication you need a backwards and forwards. And please, at the end of this, you guys are engaging with the content that we are producing, but we would like feedback. Obviously, it is specific to the South African and Cape Town or Western Cape context. There is information within it that is relevant across the continent and across the world, and we hope that it does help in clarifying some aspects. Good. So let's go back to the beginning. So this is just a screenshot from what is on my computer, and this started at the beginning of April with a list of topics. Dr. Lauren Lai King and Dr. Kambaram and I brainstormed a list of topics that we found or thought were interesting, that we thought we wanted to know more about, and we thought that clinicians in our environment would want to know more about. We didn't intend for it to become bigger than that, and because if it is being spread and if it is being used, that's fantastic. But the intent was more to inform ourselves and our colleagues about COVID-19. And as you can see from the topics, that we started relatively small. And I think part of that is, we're new to this. It's not something that we do in our daily practice. It's we do teach, we're involved with teaching, but actually generating content that is applicable to your setting. And so we started small, and we started with topics which we thought were manageable. We found a format that worked for us, PDFs with links embedded, linking to content outside of the PDF, so that clinicians who want to engage further with the information are able to, but that distills down the literature or the evidence or what we found into bite-sized chunks that people can understand. As we've got into it, they've become a little bit more intense, and a lot more effort has gone into their production in terms of their content. And I think that's part of the growing experience. So why do we do this? I'm a clinician. I'm usually on the EC floor, and it's really there because we're here to help. Sometimes we save lives, sometimes we don't. And most of those decisions and how we help needs to be based on evidence. Now, that's difficult in the African context and even in the South African context, because a lot of the evidence that we rely on isn't being produced in Africa or in low-income or low-middle-income countries. And even if it is, it doesn't always speak to the unique variables of the environment that we work in. So often we fall back to a good argument or justification as to why we are doing something or why we're not doing something. The idea also was to avoid controversy. You can build a reputation over time, but in a matter of seconds that can be destroyed. At the same time, we wanted to stimulate discussion around these topics, and so that people could have their own conversations in their ECs as to what they should be doing specific to their context or specific to what resources that their institution has available. So I'm going to jump ahead to Rapid Review 5, and the Rapid Review focused on a concept which I'm sure you're all familiar with, the reproduction number, speaking to reducing the number of infections that will be transmitted by an index case. And it's quite clear that by reducing the reproduction number, that we slow the spread of the virus. And in the context of South Africa, this has meant saving many lives, and across the world, it has meant saving many lives. The easiest way to get control of the reproduction number is what I like to term enforced physical distance. And it's something that most countries at some point have done with varying degrees of effect. But there's no doubt that in terms of dropping the reproduction number, enforced physical distancing, lockdowns, stay-at-home orders, closure of business, stopping public transport, closing schools is the quickest way to get control. This picture that you can see here came out of Rapid Review 5. That was done, I think this came out on the 20th of April. And this is where we were at that point. And most countries by that stage had spent some time in a lockdown. We'd seen a drop-off in our daily cases. And it bought us time. Now, buying time has meant that the health system has been able to prepare. Now, wherever you are, that may mean a few extra beds. It may mean just preparing yourself or your team for what's about to happen. But those health systems and that time has been invaluable in most settings. Whether that's been able to redirect resources or reallocate staff, it has bought time. But that time has also meant that other mitigation measures have been able to be put in place. These are mitigation measures, although schools are still closed in South Africa mostly, mitigation measures around schools, around the job and employers, in facilities, in public transport. Anything that we can do to decrease that reproduction number will mean a slower spread which will allow our health systems to cope with the surge in cases. Ultimately, as we come out of the enforced physical distance, it relates to behavior change. And the messaging around behavior change is very, very important, relating to physical distance and hygiene. Now, it's unlikely that lockdowns or stay-at-home measures can be repeated. I think we've seen that in South Africa, and because of the cost. This is where we are now, and as you can see, we're on an upward trend. Most other countries instituted lockdowns following a small or an initial peak of some sort, and so they've seen a decrease in the numbers. We instituted a lockdown relatively early, and we're on our trajectory up. Where that will peak and when it will peak is up as a matter of debate, but there's no doubt that there is an increasing number of infections, and that there will be a significant burden on our healthcare system. It's, as I mentioned earlier, it's unlikely that we're going to end up in another lockdown scenario because of the costs involved. Now, there's multiple costs to society: loss of employment, loss of jobs, the breakdown in trust and cohesion. And so bringing it back closer to what's applicable to the EC, in Rapid Review 9, we looked at some of the pediatric implications around the pandemic. And I'd like to spend a little bit of time focusing on that. So, children appear relatively protected from infection and severe illness. They're less likely to get the infection in a household where they're not the index. They're unlikely to be the index case in a household. When they do get the disease, it's less likely to be severe. And even when they get the disease, they're less likely to spread it. And so we live on a continent where there are a large number of children. And this is very, very important because the pandemic has the potential to reverse gains that have been made in reducing morbidity and mortality for children under the age of 5. And there are a number of reasons why. And so in the pediatric rapid review, we spoke a little bit about this. We obviously spoke about the clinical concerns, but from a pediatric point of view and the effects that it may have, I would like to just draw your attention to a few things. So number one is delayed presentations. Now that's for a number of reasons, but a lot of that relates to fear of the disease, transport systems that are no longer operational. We used to delayed presentations in our environment. A lot of what we see is as a consequence of a delay, and the severity of disease or late stage disease is often to a delay. And so it's not something that we're unaware of, but it's something that may, in the setting of the pandemic, get worse. This has significant implications, particularly for other illnesses, malaria, diarrheal illnesses, and other pneumonias, which will also be presenting at this time. But it also has a consequence for more indolent and subacute infections, so that children may present even later than they would have in the past. The knock-on effects to primary health care. Immunization programs and early recognition of disease occurs at primary healthcare levels. Food programs alleviate food insecurity in a lot of areas. The effects of this may be that vaccine-preventable diseases start to reoccur, and this will have a knock-on effect on the healthcare system. And where food insecurity gets worse, we may find that there are much longer-term effects in terms of child health and morbidity and mortality going forward. The third thing is social concerns. So speaking specifically to households and communities, increased unemployment, loss of childcare, particularly where grandparents may die, may affect family stability or the potential for people to work. There's potential for alcohol abuse and domestic violence, and also the potential for non-accidental injury because of the social stresses involved. And then lastly, issues around service provision. basic utility, basic services, water, which is obviously a significant issue already, but service that is already there falling apart, but also relating to food security, refuse, sanitation, and there are lots of potential consequences of these. And the people most likely to be affected are those children under the age of 5 or people who are vulnerable. Also in the pediatrics, we looked a little bit at some of the questions around the testing. I'm going to just speak a little bit here about the rapid reviews themselves. I don't know how many of you have engaged with them, but what we've tried to do is we've tried to use evidence that is available in the literature, and the QR codes that are linked or embedded into the document will link to references. And we've also used QR codes in other parts of the document where we feel that a little bit more information or discussion is warranted. And testing is something that has been done differently in different countries, and there's various ideas around testing or what should be doing, and it's very difficult and very dependent on what resources are available in your environment. But essentially what we pulled out of it was that prioritizing tests to improve turnaround times for those hospitalized, protect staff and other hospitalized patients, recognizing that there are significant challenges around testing on the continent, but even within our setting. As of the 1st of June, we've had to change our testing strategies in line with some of the comments that we made in this rapid review. Bubble CPAP is something that is used throughout the continent, particularly for children with pneumonia or respiratory illness, and the concerns around aerosolization of the virus and risks to staff do exist, but remembering that this therapy makes such a big difference to children and their outcomes, it's not something that should be withheld. And we speak to a little bit about that in this rapid review as well. In rapid review 6, we had a look at the diagnostics. And some of the challenges around the diagnostics. We've got, obviously, I can speak to the diagnostic strategy that we've used here in South Africa. But as I said, as of the 1st of June, that changed. And, the diagnostics for COVID have been about trying to identify infections early, to test, to isolate, to track, and then to quarantine those who are contacts of those index cases. Now, early in the pandemic, that was a possibility, but because of not the tests themselves having a high sorry, my mind's gone a little bit blank. A false negative rate of about 20 to 30%, and also the processing time for the tests, where we were able to do samples or swabs, but the processing time became very extended. It limited the effectiveness of our ability to test, isolate, track, and quarantine. And so, as a mitigation measure, it's still important to be able to test, but in our setting, we've already seen that we've had to change that. In this rapid review, we spent a lot of time on frequently asked questions. And obviously, these speak to some of the specifics in our setting, but I think the questions around the testing, and I'd encourage you all to have a look at the rapid review and specifically the frequently asked questions, because as clinicians, speaking to sensitivity, specificity, why are we doing certain tests, what are the consequences of certain tests, is important. Going forward, the antibody detection is going to be very necessary. We still don't have any serology testing available, but I think it will become of increasing importance, and we await antibody detection or serology testing in our environment. In Rapid Review 7, we focused on a bit of the COVID-associated coagulopathy. Now, COVID involves the initial infection, but a very prominent post-inflammatory response. That inflammatory response has resulted in multiple complications. Some of those have been associated with what is being termed a COVID-associated coagulopathy. We're seeing increased venous thromboembolism as a result of that coagulopathy, but at the same time, some patients get a DIC. And questions around thromboprophylaxis have arisen. Are we giving the right amount? Are we giving too little? How much? When? Should we be giving BD doses? And the Rapid Review 7 speaks to some of the challenges involved with this decision making. Different countries or different settings, different hospitals have used different strategies. And I think we really need to distill it down to what is applicable in our environment and what can be achieved in our environment safely with the evidence that we have. There's a little bit about anticoagulation as well. And essentially using some of the evidence to suggest that we do need to be at early initiation of thromboprophylaxis in patients who had increased risk of disease severity or patients who are admitted, and ensuring that they do receive thromboprophylaxis, as it more than likely will improve their outcome. As to how much in different settings, there's been a recent guidance that has come out following the production of this rapid review, which suggests that 0.5 milligrams per kg BD is adequate. And I think it all speaks to ensuring that the per kilogram dose of your thromboprophylaxis is adequate. Things that I haven't touched on now specifically are respiratory support and proning. Now, these were done by Dr. Clint Hendricks a little while ago in a previous presentation, and the use of PPE and N95. And all of these have been part of the rapid review series, and I'd encourage you to take a look at them. Over the last few weeks, as the numbers of patients have increased in our environment, we've been drawn away, not from the rapid reviews, to look more specifically at some of our local data with regards to mortality. And so we haven't been able to focus attention on the rapid reviews as you've seen them. And we hope in the next few weeks that we will be able to get back to producing the rapid reviews. And some of the topics that are still in our list of things to do include COVID and the heart, immunity and questions around immunity. Will there be lasting immunity? And with the immunity, also vaccines. Questions around therapeutics and what's available in our setting and what's likely to make a difference for our patients. There's still lots of debate around some of the therapeutics, and we await further evidence for their use and whether they're going to make a difference. As I've said before, whether they make a difference in our setting is a far more complicated question. And then the non-respiratory manifestations of COVID disease. There's good evidence that people who are either prone to diabetes or are more likely to have increased blood sugars and what these implications will be, but also the effects on the kidney, the effects on the brain. We've seen people with stroke and the effects on the heart. And so we're going to look a little bit at some of the non-respiratory manifestations and complications of the disease. And then the recovery period. Now, it's a long way before we begin recovery, but patients who are discharged, patients who've had severe or even moderate disease do have long recovery periods. And what's required for patients is also going to need some discussion. Just to leave you with something that I came across in the Lancet, and it was quite a powerful statement because it speaks to pretty much everything that we will be going through, and I'm going to read it. A pandemic is a cause and a powerful amplifier of suffering through physical illness and death, through stresses and anxieties, through financial and social instability. The alleviation of that suffering in all its forms needs to be part of our response. Now, all of us feel that stress and that anxiety and that fear. We form a very small part in alleviating that suffering. And I know it's a lot of numbers, but I want to stress that the majority of people will do well. The majority of people will recover from the disease. But because we're at the leading edge, we will see the worst of it in all its forms. The consequence of the disease, or the consequence of the complications of the disease, or the consequence of the long-term effects on health, but also on society. And so, unfortunately, because we're at the leading edge, we'll see the worst of that. And I'd like to encourage all of you to support each other through the process. Sorry, I'd like to encourage everyone to support each other because unfortunately, things are going to get worse, both in our environments and in your environment. And we're going to need each other's support through this process and through the disease. And this too will end. There will come an end to the pandemic. It'll change shape, it'll change form, and we need to be willing to change our response to it. And part of the production of these rapid reviews is to help people, number one, make decisions, but also to stimulate discussion and provide content that is relevant to our environment. I'd like to say thank you to you for listening. I hope some of that has been useful. I definitely want to encourage you to have a look at the rapid reviews if you haven't. If this is the first time you've heard about them, we've spent a lot of time producing them, almost in a vacuum at times. And the content spoke to us, it spoke to some of our clinicians, and I hope it speaks to some of you. And I'd encourage you to adapt it, use it, use the concept in terms of sharing information or building your own resources for your environment. There's also a few other people that I'd like to say thank you to, and my co-authors, Lauren Lai Kim and Kamlin Cameron, and then people who have given advice on certain of the sections as well. Thank you to your input. It is an ongoing process. We all learn through it. I've learned a lot in developing some of the content, and we hope to be able to provide more content that is relevant to you, but also encourage you to develop your own, because it speaks to our environment, but I can't speak for beyond that. And you will know your challenges better than anyone, and you'll know your environment better than anyone. And the best way to deal with fear, the best way to deal with misinformation is through communication. Communication that is relevant, that is evidence-based, and where there isn't evidence, where there is good argument and good justification. Thank you for your time, and I hope you have enjoyed some of my presentation.
Thank you so much, Dr. Bush. That was a really great presentation, and I know that a lot of what you've presented can be adapted and used across a variety of different contexts. And in addition to that, we've heard from a lot of our different attendees and members that discussion around clinical management is incredibly important to them, so these rapid reviews are an essential piece of that. And as Dr. Bush was saying, these rapid reviews are accessible to everyone online. So if you go to afem.africa, you can access all of the rapid reviews that Dr. Bush walked us through, as well as additional ones. And as his team continues to produce content, we will be sharing them on our AFEM website and hopefully more on the webinar as well. As I mentioned before the beginning of the presentation, there are two questions that I've posed one of them already that we'll be posing for you to think about with regards to these rapid reviews and just some more clinical discussion to be had. So feel free to respond to that question. It's already in the chat. And then I'll post the other one soon. And then in the question and answer section at the end, we'll leave space for you all as attendees to discuss your thoughts on those two questions and on the presentations in general. So we're now going to move into the question and answer section. I realize that we're just at time. So if anyone has to sign off, we definitely understand. But I do want to try this because we have a bit of a smaller group today. This would be a perfect opportunity to try a discussion and just see what people's experiences as they sort of share about the presentations and about the questions that we posed in the chat. So I've just allowed all of you the ability to use your audio, so you should now be able to unmute yourselves.
I've seen the 2 questions in the chat, so I can speak to some of that unless, there seems to be some more questions in the chat coming through, or... Okay, so some people adding some comments to the chat. I think the question around testing strategies, and I think the World Health Organization has provided a good guidance as to testing strategies during what phase your country is during the pandemic, specifically speaking to the resources that you have available and your priorities. And I think that's different for each environment. The ability to test and suppress transmission, I think, has been shown to be very limited, even in our environment where we've thrown significant resources at testing. And we've had to change our testing strategy, as I mentioned, and that's become more in line with what the World Health Organization's guidance is as to testing. So I think that needs to be decided on what you can achieve and what's the best use of resources in your local environment. At the end of the day, that might be relying on a case definition if you don't have testing available or the turnaround time is too long. But for me, the priority is actually trying to protect healthcare workers and in helping clinicians make specific decisions around patients who are in hospital, particularly where it may not be COVID or it could be a complication of something else, and it takes you down a very different trajectory. And so, if you don't have testing available, then it may be a chest X-ray, it may be some clinical signs, and a case definition. But if you've got testing available and the turnaround time is reasonable, then patients who are admitted and in light of trying to protect healthcare workers would be a strategy in a sort of a resource limited environment.
Thank you for giving that insight, and I think we do have some more responses in the chat.
I see Sarah had a comment about the dexamethasone question, and obviously it's topical at the moment. It's something that we haven't really specifically looked at yet. I think the picture isn't clear. Number one is if we take it at face value, what has been put into the media and what has been published, patients who have an oxygen requirement or who need critical care level hospital care do appear to benefit. So let's take that at face value. They also include that patients need to have most of their patients had a positive diagnosis, which may be a challenge in our environment. It included their normal package of care, which is very different to our environment here and probably your environment across the continent. And so, although they have achieved some good results, we don't know what it will achieve in our setting. I'm pretty sure that many of our ICUs and critical care fellows are already using steroids, and we're not seeing very good outcomes in our ICUs. And so, yes, there is some evidence, and I think you'd have to say that if you have an oxygen requirement and if you're needing any advanced respiratory support, that there appears to be a benefit from steroids, and that I wouldn't withhold steroids. As to using steroids more broadly in a preventative strategy, there are significant risks to the use of steroids. If we are unable to test and make sure that those patients have COVID, you're potentially giving someone steroids who has a totally different disease process, yes, respiratory or complication, and that may have other effects which we're not able to measure or have any idea of in our environment. So, part of our practice needs to be evidence-based, and so I wouldn't expand beyond that unless there's evidence for it.
Does anyone else have any thoughts or questions?
I guess this is Sarah. I feel like the most common dilemma that we're running into is we're seeing a lot of patients coming in with tuberculosis, either known tuberculosis that's already been diagnosed or very likely tuberculosis that hasn't been diagnosed yet. But they're coming into the A&E because they're acutely worse and they're critically ill, and the test is taking too long. We really can't use the test for emergency treatment at all. I was just curious if anybody has come up with sort of a kind of a decision-making tree for how they approach these the other conditions presenting as COVID, as far as trying to separate the COVID patients, or getting things like a sputum sample for TB in a patient who might have COVID. I'm just curious if anybody has come up with a good protocol for that.
I can give some thoughts, but as to specific protocols, I mean, we've divided into non-respiratory and respiratory. And unfortunately, anyone with a respiratory complaint, because we've got significant amounts of community spread, is treated as a patient under investigation. You know, the acutely unwell TB patient is thrown in there. Often, depending on where you present in the disease, it'll obviously be a different presentation. But you know, most of the TB that we see here is of a more indolent subacute process, whereas I think the rapid deterioration of COVID is slightly different, but the two together is incredibly complex. And it is a challenge. I mean, we've seen a big drop off in the numbers of our patients being tested for TB. That doesn't mean TB's gone away. It means it's spreading. And it's going to be a challenge on the other side of this. So I don't have a good answer. It's an answer. I think we do need to be doing chest x-rays when they are available to give us an indication of, does that picture look like TB if you have that available in your facility, and then really asking, does this fit a case definition? Does it look like COVID? And if it does, it has to be treated as COVID. And obviously, you know, the people will either get better or get worse. You know, obviously in those patients, we want to try and avoid dexamethasone with our high TB load. So it's good questions, and I don't know if we're going to have a clear answer. It'd be nice to have rapid testing, far more rapid testing. But you know, even in our setting, we got to a point where some of the tests were coming back a week to 14 days later, and that doesn't help the patient that you're seeing, and it doesn't help from an isolation, quarantine, reducing transmission point of view.
Just as a follow-up to that, if you have patients who have known or suspected TB and are also COVID suspects or under investigation, are you isolating those patients together? Do you isolate TB patients separate from the rest of the COVID patients? Like, is there any consideration for that?
So, you know, in our setting, we have a lot of TB in the Western Cape, and so TB is part of sort of our daily practice, and you are almost as likely to get TB in your own community and home as you are more likely in your community than at hospital. So the only TB patients that we really isolate are those with drug-resistant TB. So in our medical wards, we try and isolate where we can, but it's not, we aren't able to. And during COVID, they're not being isolated, is my understanding, unless they are known with XDR, NDR. But even then, if they're on adequate treatment, we don't isolate them specifically. So, you know, it's only those that you wouldn't, who have a new diagnosis, not on treatment. Yeah.
Okay. I think what happens in like the county hospital here is that you end up stuck in the emergency department. You end up stuck between those two tests, the TB test and the COVID test. And you can't find a ward to, either they won't admit the COVID patient because the TB test isn't back, or they won't admit the TB patient because the COVID test isn't back. So we end up managing them for like 5 days in the department. So I was just curious if anybody had run into the same problem and come up with a approach.
I think that the systems that have been put in place here are to try and offload our emergency departments as much as possible. Number one is you have people presenting who don't have COVID, and you increase their risk. And in COVID wards or patients under investigation wards, which is the way we sort of term it, you will have a combination of COVID positive and people who turn out to be COVID negative. And we've got community spread. It's not something we can be 100% of. And obviously turnaround times for tests are important, but we have COVID wards, patients under investigation, and then patients who don't fit the case definition in separately. So we have tried to separate, but it's clear that we can't stop spread. It's all about limiting spread and decreasing risk to people who are at high risk. We will get some things right and we'll get a lot wrong, but I don't see another way through that.
Thanks.
Great. Thank you so much, Luke, for taking the time to answer those questions. And thank you, Sarah, and everyone for participating and asking some questions. Just generally, this, I think, wraps up our presentation for today.